start the topic. So my topic here is supracondylar fractures with intercondylar extension in adults, tips, tricks and hacks to fixation. So as you all know, these are complex fractures because of the complex anatomy, the usual combination with a less bone stock and proximity to neurovascular structures. It has always have a bimodal age of distribution. In young patients, it usually results from high energy trauma, and in elderly patients, it's due to the osteoporotic bone and mainly low energy mechanisms. So our understanding has greatly evolved due to the AO principles of plate and screw fixation, widespread availability of CT scan with 3D reconstruction, recognition of these complex fracture patterns, understanding the benefit of parallel and 1990 plating techniques, availability of pre-contoured plates, and selective use of total elbow arthroplasty. So I'll be dealing with the type C fractures, that is 1-3C, that is C1, C2 and C3. As you all know that C1 is metaphyseal simple and articular simple, C2 is metaphyseal comminuted and articular simple, and C3 is metaphyseal and articular comminuted fractures. Regarding the evaluation, we have to stick to the general principles. We have to assess the soft tissue status, the neurovascular status. We have to identify the associated injuries, and the imaging should be adequate. Usually we get a AP and lateral views in a very compromised position, but always see these might be the images we get, but you get a better view with a traction view, which is done on table or with a sedation. The 3D CT will definitely help for the further management protocols. Coming to the management, non-operative treatment is very rarely indicated for very undisplaced fractures, patients at very high risk for anesthesia, frail or low demand patients, and usually associated with poor outcomes like non-union, malunion and joint stiffness. The goal of operative treatment is to restore the joint integrity, enable joint stability and early functional rehabilitation. Coming to the operative treatment one by one, K-wire fixation and percutaneous screws, they don't give adequate stability, hence they are not recommended for adults. And the gold standard is open reduction and internal fixation. Good functional outcomes usually result from early total care, which helps to establish in early exercise stable conditions and early functional rehabilitation, which also reduces the complications. In case of severe soft tissue injuries, don't hesitate to put an external fixation of the elbow joint, and that should be preferred. Now, what approach? The choice of approach for type C is the dorsal approach. The entire joint can be exposed. We have gone through these several types depending on how the triceps is handled. Like the muscle is either split centrally, or it can be pushed to the side in triceps reflecting approaches, or it can be removed by osteotomy of the olecranon, or we can maintain the triceps attachment by using a paratricipital approach of medial and lateral openings. Or my preferred approach is para-olecranon approach, that is the lateral para-olecranon approach. What type of plates, how many plates and what configuration? Coming to what type of plate. We have several types of plates, 3.5 mm straight plates which are intraoperatively contoured. We have the pre-contoured plates for parallel plating as well as perpendicular plating, Y plates and 1/3 tubular plates. 1/3 tubular plates are too weak and prone to breakage. The pre-contoured plates, they are anatomic and they help to reduce the duration of surgery. They've got superior biomechanical properties with high density of screw placement in the distal humeral articular segment. They are more costly. So a good fixation always requires two plates, either parallel or perpendicular. Perpendicular plating was introduced by Jupiter in 1985. Criticism is poor screw purchase in the sagittal plane, especially in the posterolateral plate. Advantage, the coronal shear fractures are well handled with these type of plating. Parallel plating, which was introduced by the Mayo Clinic group in 2005, placement of long screws in the distal fragments from each plate in the mediolateral direction. There is triple plating. It's a combination of both. That is, there is another plate in the lateral aspect, which is technically difficult and there is no major advantage. Other type of plating is the Y plating, where the interfragmentary part is held with the interfragmentary screws, or the intraarticular part is held with the interfragmentary screws, and the Y plate is used for the diaphyseal component. There are several studies which compare all these types of plating, but the important ones are the one in 2013 by Lee, which states that there is no significant difference with respect to clinical outcomes and complications in these both type of platings. Either it is a perpendicular or parallel configuration. Another study, these two studies tell that there is no significant difference. Now, how to fix? For C1 and C2 fractures, it is completely articular fractures. So this is a type C. Either you can convert it to type A, that is, you can reduce it intraarticularly and then do the final fixation, or you can convert it to a type B, that is, you reduce the bigger one to the stable fragment, and then you convert it to type B and then proceed with the final fixation. So the classic AO technique, you fix the articular fragments, that is, 1 or 2 screws are placed in the coronal plane, followed by orthogonal plate fixation. Drawbacks, there is limited anchorage of the plates on the distal fragments, limited compression at the supracondylar level. This is the 1990 parallel plating. Here, this is by the Mayo group. It is for maximizing the fixation in the distal fragments. So it has got 8 principles. That is, each screw should pass through a plate. Each screw should engage a fragment on the opposite side that is also fixed onto a plate. As many as screws should be placed in the distal fragments. When it is a type C3, the basic goal is to realignment of the trochlear width, and which helps to increase or enhance the inherent stability of the elbow. Here we can use the headless or countersunk screws for small fragment. If there is bone loss, you can either do a supracondylar shortening or bone grafting. Elbow arthroplasty is very rarely used. It is for a selective group of elderly patients where there is a pre-existent symptomatic pathology, comminuted fracture with substantial osteopenia, when there is severe damage to articular surface. Post-operative rehabilitation, active motion using gravity-assisted maneuvers within the first 48 hours. ROM exercises to the tolerable limits of pain with gradual improvement is expected in 4 to 6 weeks and should be supervised. When there is limitation, night extension splinting is good. Complications, elbow stiffness, heterotropic ossification, neurological injury, non-union, olecranon osteotomy non-union, and hardware prominence. Coming to some cases, so this is a 33-year-old female, road traffic accident, closed injury, no neurovascular deficit. So that is the X-ray. So I went by the para-olecranon approach. So that is a reduction, provisionally reduced, then fixed, gave intra-articular compression with the compression device. So that is the compression screws from the lateral side, and then proceeded with the final fixation. So that is the immediate postoperative X-ray, and that is a function at 2 months, and that is a function at 6 months. Coming to case 2, this is an 83-year-old female, fall at home, closed injury. So that is X-ray and the CT reconstructions. Again went by the para-olecranon approach. That is the immediate postoperative X-ray. And I had only 1 month of follow-up. That is the moment at 1 month. And this is case 3, a 23-year-old female, road traffic accident, no comorbidities. That is X-ray. So that is after final fixation, her ROM on table. Immediate post-op and 1 year follow-up without any issues. Case number 4, 64-year-old female, fall at home, CKD on dialysis. She has got an AV fistula on the same arm, so that was a difficult fixation, but she got a full range at 2 years. Case number 5, it's a 33-year-old male with road traffic accident. So that is the X-ray and 3D CT scans. When by the paraolecranon approach, that is the 1-year follow-up. Case number 6, this is a case of 45-year-old male with fall from height, type 1-3C2 with segmental loss of distal humerus. So that is the X-ray at presentation. So here a better imaging is a portable traction view. So that is a portable traction view after giving anesthesia. That is a CT scan. And I plan for a staged procedure, that is initially plan for a wound debridement and external fixation, and intra-articular reduction and fixation, and cement spacer, and later a gap management. So that is the immediate post-operative images. X-fix. Next week I went for a cement spacer and intra-articular fixation. So after 6 weeks, went ahead to manage the gap. Either I can do a Ilizaro or what I did was I took a titanium cage with bone grafting and supported with the plate. So that is the follow-up X-ray. It's been 4 months. That's his range of movement now. That's the last case. 43-year-old male, fall from height. Here it's more articular comminuted, so I went with a olecranon osteotomy approach. So that is the articular reduction which is attained. Then went ahead with fixation. That is 6 months follow-up. So the take-home message is the treatment for humerus fracture or distal and humerus fracture continues to improve. Pre-contoured plates revolutionize the operative fracture care. A careful pre-operative planning. We have to follow the principles and precise surgical execution. Thank you.